Thanks to the organizers for inviting me for this session on ER positive breast cancer. I have 7 papers. One is the pooled analysis of the Monalisa trial, abemaciclib as adjuvant, palbociclib as neoadjuvant, 2 subgroup analysis of the Penelope trial, and 2 trials of a new class of drugs, the CDK7 inhibitor. So let's look at the pooled analysis of the Monalisa trial, basically looking at the patient reported quality of life in the Monalisa 2, 3, and 7 trials, which are trials of ribociclib plus endocrine therapy in hormone receptor positive advanced breast cancer. So we now know that patient-related quality of life are important in terms of clinical decision making. And as you know, the Monalisa 2, 3, 7 trials tested the efficacy of ribociclib with different endocrine therapies. And in each of these phase 3 trials, patient-related quality of life was separately explained. Pooling these trial data probably will enable a robust analysis of the quality of life. So the objective is to assess the time to deterioration by at least 10% in global health status, pain, fatigue, physical, emotional, and social functioning subscores of the EORTC Quality of Life Questionnaire C30. We'll also look at the change from baseline in global health score and pain when the patients have progressive disease. So all the patients from Monalisa 2 trial were included, whereas Monalisa 3 and 7, only patients who received first line in 3 and patients who received the non-steroidal aromatase inhibitors in the 7 were included. So you can see that ribociclib significantly improved the time to deterioration by more than 10% in the global health score, in the pain, in terms of emotional functioning, as well as social functioning. However, there was no significant difference in terms of fatigue and physical functioning. In patients who had progressive disease, both ribociclib and placebo, there was significant improvement only when the patients had a response compared to patients who had progressive disease, in both in terms of health score as well as in terms of deterioration in terms of pain. So this robust pooled analysis of 1,528 patients in this trial demonstrated significant improvement in quality of life when patients received ribociclib in addition to endocrine therapy. And this treatment was associated longer maintenance of quality of life, pain, time to deterioration by more than 10% in terms of emotional and social functioning. Only thing is not much improvement in terms of fatigue and physical functioning. However, no deterioration either. So addition of ribociclib to endocrine therapy significantly improves the overall survival in these patients as well as maintains the quality of life. So if you look at the second study of abemaciclib as adjuvant, we all know the Monarchy trial. Basically, this is a subgroup analysis of patients who have received neoadjuvant chemotherapy. Monarchy trial was a phase 3 open label randomized study evaluating abemaciclib combined with adjuvant endocrine therapy compared to endocrine therapy alone in patients with high risk early breast cancer. We know that in early breast cancer, neoadjuvant chemotherapy is used in patients who have got higher risk of recurrence, and this is despite limited pathological response often. And the clinical and pathological stage prior to and after neoadjuvant chemotherapy is shown to correlate with patient outcomes. Here, we present efficacy and safety data for patients enrolled in Monarchy trial who received neoadjuvant chemotherapy. We all know the inclusion analysis of this. I'm not going into the details, but we also know that tumor size more than 2 centimeter seems to have some bad results with these patients. So if you look at patients who have received neoadjuvant chemotherapy, when you give ribociclib, there is significantly abemaciclib, there is significant clinically meaningful improvement in invasive disease-free survival of around 38.6%, reduction in the risk of developing an IDF event. And the 2-year invasive disease-free survival rates had a difference or delta of 6.6%, and the distant recurrence-free survival had a delta of 6.7%, again showing a clinically meaningful benefit in distant recurrence-free survival. So concluding, in these patients, we know that patients who received neoadjuvant chemotherapy had an increased risk of recurrence compared to the intent of treat population. And in patients who received neoadjuvant chemotherapy, abemaciclib, when combined with endocrine therapy, demonstrated a clinically meaningful benefit in both in terms of invasive disease-free survival and distant recurrence-free survival. And this is independent of the size of the tumor. So the third study is palbociclib as neoadjuvant therapy. So this is the NeoPal study, letrozole and palbociclib versus the chemotherapy as neoadjuvant treatment in luminal breast cancer. This is a survival result analysis. So this was a small study. So patients with newly diagnosed stage 2-3 breast cancer who are postmenopausal and who are strongly ER positive were taken up, and they were randomized to letrozole plus palbociclib for 19 weeks or the standard 3 FEC 100 followed by 3 docetaxel 100. So if you look at the number, it's only 106 patients. 53 received neoadjuvant chemo, 53 received the hormonal therapy. Post surgery, all who had a RCB 0 or 1 were given only hormonal therapy, but all the patients with RCB 2 and 3 were suggested chemotherapy, but not all of them took it. So if you look at it, in terms of pathological response, stable, partial response, complete response, stable disease, both of the arms were more or less the same. In terms of progression-free survival, there was no significant difference. There were 3 progression in the palbociclib letrozole arm and 8 progressions in the control arm. There was no significant difference in terms of invasive disease-free survival, but notice that 6 deaths occurred in the letrozole and palbociclib arm. 1 was suicide, 1 was alcoholic cirrhosis, 2 had intercurrent disease, and only 2 deaths were related to breast cancer. Whereas in the control arm, there was 1 death and it was directly related to breast cancer. Because of that, you can see that there is a difference in overall survival between the 2 arms, but no difference in terms of breast cancer specific survival. In terms of the RCB score, that is the response to chemotherapy score, patients who had a significant response in the palbociclib letrozole arm were not given chemotherapy, and hence they did not have that great response in terms of progression-free survival. So when you look at the exploratory survival according to chemotherapy given, there was no difference in breast cancer specific survival or invasive disease-free survival, but there was some difference in terms of overall survival. So I think in this high-risk population of early luminal A but node positive or luminal B breast cancer patients, neoadjuvant combination of letrozole palbociclib led to significant pathological response, which was same as chemotherapy, equivalent clinical response in breast conservation surgery rates, equivalent progression-free survival, invasive disease-free survival, but we need to remember there is some difference in terms of overall survival. This study is underpowered and it is just a hypothesis generating study. So let's look at the Penelope trial, which has been, multiply time analyzed. These are 2 subgroup analysis more. So we all know the Penelope trial, which took up patients with hormone response positive breast cancer. No PCR after neoadjuvant chemotherapy were taken into this trial. So patients underwent neoadjuvant chemotherapy followed by surgery and radiation, and then were randomized to palbociclib versus placebo. You can see that the primary endpoint of invasive disease-free survival in the trial was negative. Both the arms did equally well. So this is a subgroup analysis of premenopausal patients. So premenopausal patients received either tamoxifen alone, tamoxifen plus GnRH analog, or AI plus GnRH analog. You can see that majority of them, 2/3 of them, received tamoxifen alone. Now, in this subgroup analysis of premenopausal patients, in that subgroup of tamoxifen plus GnRH analog, there is a significant difference in the 3 years disease-free survival, 74% versus 83%. Notice there is no difference in disease-free survival when you use tamoxifen alone, which was a majority, and AI plus GnRH analog. In terms of adverse events, tamoxifen plus GnRH analog was slightly superior in compared to AI plus GnRH analog. So leading to the conclusion that the overall results did not show improvement. However, in a small subgroup of premenopausal patients receiving tamoxifen plus GnRH analog, there is a numerical superiority of palbociclibs and requires further trials. So another subgroup analysis of post-neoadjuvant luminal B tumors assessed by a tumor panel. So basically, this is the first translational research data from the Penelope B trial. And after completion of neoadjuvant chemotherapy and locoregional therapy, the Penelope trial patients were randomized to receive 13 cycles, that is 1 year of palbociclib or placebo, along with standard endocrine therapy. Now, what they did in these patients is, after neoadjuvant chemotherapy, they did gene expression in these residual tumor tissue samples using the HTG H sequence oncology biomarker panel, which is quite similar to the PAM50. Based on 91 genes of this panel, they calculated the AIMS, that is the absolute intrinsic molecular subtype. Now, there were 4 subtypes according to this. And if you look carefully, the luminal A was majority 663. Just look at the number of luminal B, which was only 64. In this trial, the subgroup analysis, patients with luminal B tumors had an estimated invasive disease-free survival of 70% compared to palbociclib of compared to 44% with placebo, suggesting that luminal B subcohort of patients did benefit from palbociclib. However, notice the small size of the luminal B subcohort, and this is not statistically significant. And also notice that luminal A tumors, there was no significant difference by adding palbociclib. So the Penelope trial did not show statistically significant benefit with palbociclib. However, a small group of patients with luminal B tumor after neoadjuvant chemotherapy potentially derive benefit from palbociclib and require further investigation. So my last 2 trials are on a new class of drugs, the CDK7 inhibitors. So the CDK7 inhibitor in question is samuraciclib, which is a small oral molecule, ATP competitive selective inhibitor of CDK7, which acts synergistically with hormonal therapy in xenograft models. It blocks all the 3 CDK7 mediated oncogenic effects, which is stimulation of cell cycle through phosphorylation of other CDKs, transcription of oncogenic and anti-apoptotic genes, signaling by and activation of hormone receptors. Now, there were 2 studies in this. This is the first in human modular 1 study of samuraciclib in patients with advanced solid malignancy. This is the module 1A. So basically, it's a dose escalation trial where they started with 120 mg, went up to 480 mg. And you can see that the maximum tolerated dose seems to be 360 milligrams. And the predominant adverse events were low-grade GI events. And the dose limiting toxicity occurred at 480 milligrams. There was no neutropenia, no alopecia, and the 2 deaths were unrelated. So there was, PK evidence of target engagement. Samuraciclib exposure was dose proportional. It was time dependent. Half-life is 75 hours, permitting once a day dosage. There is high volume of distribution indicating accumulation in tumor and clear reduction in CDK1, 2 and phosphorylated RNA polymerase 2, suggesting good benefit. So there were multiple patients who showed benefit with the disease control rate of around 60% at 240 milligram and 65% at 360 milligram. And there was a prolonged disease control group in triple negative breast cancer expansion cohort also. So in this trial, they concluded that it is a once a day daily dosing. 360 milligram was the best supported dosage, and there seems to be anti-tumor activity. The last trial is basically presented at San Antonio, which was a phase 2 trial of samuraciclib along with fulvestrant. What they knew is first line standard of care is CDK4/6 inhibitor plus aromatase inhibitor, but there is nothing after that. There is no current agreed standard of care for treatment once they progress on CDK4/6 inhibition. So this is a modular 2A, basically looking at patients who have progressed, and they thought of samuraciclib 240 milligrams, and then they went up to 360 milligrams. You can see that there's this durable efficacy. The overall clinical benefit rate at 24 weeks is 36%. No liver metastasis is 55%, and patients with P53 wild type was 53%. And of evaluable patients, 72% showed benefit. And somehow with P53 mutation status, it seems to vary. And this is much greater than other therapies. Preclinical data indicate that CDK7 inhibition activates P53 pathway and cause apoptosis. So hence it is beneficial. So concluding, samuraciclib plus fulvestrant is active in CDK4/6 inhibit pretreated hormone receptor positive breast cancer, co-administered with oral SERDs. It has been granted fast track status. So lastly, to summarize all the 7 trials, addition of ribociclib to endocrine therapy improved overall survival in patients with advanced breast cancer, also maintained the quality of life. Abemaciclib combined with adjuvant endocrine therapy in high-risk early breast cancer who received neoadjuvant chemotherapy is useful. Preoperative non-chemotherapy approach with palbociclib with the NeoPal study is to be thought of. The Penelope subgroup analysis showed improved movement with palbociclib in premenopausal women and with luminal B subtype. And samuraciclib is a once daily oral small molecule CDK7 inhibitor with combination with fulvestrant being active in pretreated HR positive breast cancer. Thank you.